Assalamu alaikum everyone. This is our first lecture of this medical diagnostic series. In this, we are going to discuss the jaundice. What is jaundice? Jaundice is the yellow discolorization of sclera, skin, and mucous membrane due to the deposition of bilirubin. In jaundice, we have a lot of bilirubin. We have a lot of bilirubin in our blood, which lead to the yellow discolorization of our sclera, means eye, skin, and mucous membrane. Let me show you some pictures. As we can see here, the eyes of patient is turned yellow. In this way, in this picture, the skin of the patient, the skin of the baby, these are all turned to yellow because of deposition of bilirubin in our blood. Now there are three classifications of jaundice: hemolytic jaundice, hepatocellular jaundice, and cholestatic jaundice. Before discussing this type, I would like to discuss this simple diagram. If you understand this diagram, the topic of jaundice is no more a problem for you. So I want you to listen it very carefully and understand this mechanism. First of all, our blood has a lot of red blood cell. As we have already know, red blood cell contain a lot of hemoglobin. Whenever our red blood cell break down, they release the hemoglobin into the blood. The hemoglobin in blood is further break down into unconjugated bilirubin. This unconjugated bilirubin is transferred from our blood to our liver, where unconjugated bilirubin is converted into the conjugated bilirubin. Our liver then creates the conjugated bilirubin through our bile, which travel to the extrabiliary system into our small intestine. This is our small intestine. In our small intestine, the natural bacteria are present. These bacteria convert the conjugated bilirubin in our bile to urobilinogen and then convert it into the sterobilin, which is excreted through feces. So sterobilin is the component which gives the color to our feces. It gives color to our feces. If we have dark feces, this means we have more sterobilin, and if it is less, if it is clay color or light color, this means we have less sterobilin. Now we are going to discuss the types of jaundice. First, we have the hemolytic jaundice, in which the large number of red blood cells are destroyed. In this hemolytic jaundice, we have problem here. Due to some disease, the large number of red blood cells got destroyed in our blood. Because we have a large number of red blood cells are getting destroyed in our blood, getting destroyed in our blood. Due to this hemolysis, we have a lot of unconjugated bilirubin accumulated in our blood. Our liver has a capacity of converting unconjugated bilirubin to conjugated bilirubin. Now, the amount of the unconjugated bilirubin surpass the liver's ability to convert the conjugated bilirubin to unconjugated bilirubin to conjugated bilirubin, which lead to the accumulation of unconjugated bilirubin in our blood. That's why we have a hemolytic jaundice due to a very large amount of unconjugated bilirubin. Now we are going to discuss is etiology, means the causes of hemolytic jaundice. So from this we can understand that every disease that can destroy our red blood cell in large amount lead to the hemolytic jaundice. So in this way we here have congenital hemolytic anemia. Congenital means the by birth. Hemolytic means the process of breakdown of red blood cell is called hemolysis, and this is hemolytic from that, derived from that. And anemia means less amount of red blood cell, because we are breaking a lot of red blood cells, so red blood cell are less in our blood. So diseases like thalassemia we have already discussed is in biochemistry, another subject, and hereditary spherocytosis. In this disease, also large number of red blood cells undergo degradation. Also, we have some acquired hemolytic anemias like autoimmune hemolytic anemia, in which our body's white blood cell attack our red blood cell, and we have the hemolytic disease of newborn, which is discussed very detail in immunology, because this it happens due to the mismatch of blood between mother fetus blood type and mother's blood type, and favism, which is glucose G6PD deficiency here. So in all diseases, we know there is a breakdown of large number of red blood cells. Now we will discuss its clinical manifestation. We have light lemon skin, as we have already seen in the pictures. The patient has yellow skin. Patient has no skin itching. Normochromic anemia means the, actually let me show you. Our red blood cells are dark in surrounding, and in middle they are little light in color, and this is normochromic means this is normal. In hypochromic or hyperchromic, the light region in the middle got changed. And we have hemoglobin urea means, because as we know we are breaking a lot of red blood cells, they are releasing a lot of hemoglobin, so some of hemoglobin got secreted in our urine. So we have hemoglobin urea. Acute hemolysis means that again a break of red blood cell leading to fever, chill, headache, anemia, splenomegaly, and chronic hemolysis, which is the anemia for long time and splenomegaly for long time. So we now next another very important thing here is clinical laboratory examination. We are going to discuss the laboratory examination of these three types on next slide. First, we will discuss the hepatocellular jaundice. Hepatocellular jaundice is due to the hepatocellular damage. Means it is problem in the hemolytic jaundice. Problem is here in red blood cell. In it, red blood cell are normal, but problem is here in liver. Our liver, due to some diseases like cirrhosis, liver abscess, hepatitis, our liver is not able to convert the unconjugated bilirubin to conjugated bilirubin. Okay, our liver actually does two things. First, it converts the unconjugated bilirubin to conjugated bilirubin. Secondly, it excretes this conjugated bilirubin through bile. These are two processes. Either one of them, first converting unconjugated bilirubin to conjugated bilirubin, second excreting the conjugated bilirubin to bile. If any of them got disturbed, we have hepatocellular jaundice. So let's discuss the etiology of it. We have etiology means causes the viral hepatitis, means the viral infection of liver, some drugs that damage the liver, alcohol, cirrhosis, and liver bacterial infection of liver abscess. These all are actually damaging the liver. So it is leading to hepatocellular jaundice. In hemolytic jaundice, we have seen the all diseases which are actually affecting our red blood cell, not our liver. Here, all diseases are affecting our liver, no red blood cell. So clinical findings are yellow to deep yellow skin, mucous membrane, sclera, mild skin itch. Here we have no skin itch in hemolytic jaundice. Here we have mild skin itch, tiredness, loss of appetite, ascites, and coma. As we can see in ascites, which is one of the very common symptoms in uh, uh, hepatic disease. When our liver is damaged, our fluid start accumulating in our abdominal peritoneal cavity, and coma, which happen in severe liver damage. Now we have cholestatic jaundice. This is also called the obstructive jaundice. This is also called obstructive jaundice. It is due to the obstruction. Now, red blood cells are normal. Our liver is normal. It's converting unconjugated bilirubin to conjugated bilirubin, and then excreting this conjugated bilirubin through bile. But we have some problem in this extra biliary system. Maybe we have a stone here. Maybe we due to some tumor. These are our pancreas. These are actually connected to this extra biliary system, and sometimes we have the cancer in the head of pancreas, which cause a blockage in this flow extra biliary system. So due to the cancer, now everything is normal. Liver is producing conjugated bilirubin, but that conjugated bilirubin cannot flow to our small intestine. This also lead to jaundice. So this is due to the obstruction, or etiology means obstruction diseases like gallstones, stitch, and pancreatic duct carcinoma. We have already discussed the pancreatic duct carcinoma, and we also have gallstones here, which lead to cholestatic jaundice. The clinical manifestation are here. We have skin itch. In hemolytic jaundice, we have no skin itch. Hepatocellular jaundice, mild skin itch, and in the obstructive jaundice, we have a lot of skin itch. Again, dark yellow to yellow green, skin sclera, dark yellow urine, and light yellow and clear color feces. We are going to discuss this laboratory finding in next slide. And we have also, there is an important sign called VCS signs. So co-VCS sign state that co-VCS sign is actually to help us in distinguishing this obstruction is either due to pancreatic head cancer or not. So this sign states that if we have dilated gallbladder, first we have dilated gallbladder, means this is our normal gallbladder. In dilated gallbladder, our gallbladder increases in size a lot. We have dilated gallbladder, first sign. Second, we have no tenderness, or in simple word we can say no pain of gallbladder, because if we have some stone or something obstructing gallbladder, this is really painful for the patient. But in external obstruction like due to pancreatic head cancer, there is no tenderness, no pain. So we have no tenderness. And third, we have obstructive jaundice, cholestatic jaundice or obstructive jaundice. If these three signs are present, the most it leads us to think it is due to the pancreatic head. The jaundice is due to the pancreatic head carcinoma, not due to the stones. This is the covious signs. So I recommend you to remember this sign because examiner love to ask this sign in the exam. Also, we have another sign known as the Murphy sign, which is very important, but we will discuss it in abdominal examination.